Hi everyone, my name is Sarah Wong, and on behalf of our co-authors, it is my pleasure to present our article entitled Autoimmune Liver Diseases, Hepatocellular Carcinoma, and Recurrence of Autoimmunity Post-Liver Transplantation. In this review, we address the current literature on the risk of HCC in autoimmune liver disease, as well as the development and management of recurrent autoimmune liver disease post-liver transplantation. As we know, autoimmune liver diseases include autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. They are a common indication for liver transplantation worldwide. However, the post-transplantation course may be complicated by the recurrence of autoimmune liver disease, which adversely affect graft and overall survival. As hepatocellular carcinoma is one of the possible liver transplant indications in autoimmune liver disease, we first review the risk of HCC in this population. In general, the risk of HCC is greater in patients with chronic hepatitis B, hepatitis C, and alcohol-related liver disease as compared to those with autoimmune liver diseases. Cirrhosis is the biggest predictor for HCC development, while various other clinical risk factors have also been identified. This includes older age, male sex, and alcohol use, among others. It is conceivable that recurrence of autoimmune liver disease post-transplantation may serve as an ongoing risk factor for a recurrence of HCC. However, currently the literature in this area is limited. The diagnosis of autoimmune liver disease post-transplantation is based on a variety of clinical, biochemical, and histological features, and in the case of PSC, radiographic features as well. The pathogenesis involves a complex interplay of genetic and environmental factors, the exact processes of which are yet to be fully elucidated. A variety of risk factors have been identified as shown here. In general, the management of recurrent autoimmune liver disease can be broken down to pre-transplant optimization, post-transplant prevention, and the treatment of recurrence. For autoimmune hepatitis, control of inflammatory disease activity prior to liver transplantation has been shown to decrease the risk of recurrence. Post-transplant, low-dose, long-term corticosteroids may also reduce recurrence, though this is debated. The use of corticosteroids plus or minus azathioprine is the mainstay of treatment in the setting of recurrent autoimmune hepatitis. In PBC, the use of ursodeoxycholic acid pre- and post-transplantation has been shown to decrease the risk of recurrence of disease. Cyclosporin-based immunosuppression has also been shown to be of benefit. For PSC, it is believed that the controlled IBD activity both pre- and post-transplantation may decrease the risk of recurrence. However, as with PSC itself, there is no treatment for the recurrent disease, and the management is largely based on symptoms. The optimal treatment for the recurrence of autoimmune liver disease is still very much under study. We need to further understand these complex mechanisms that mediate recurrence of autoimmune liver disease so that we can achieve better outcomes for our patients post-liver transplant.